Swayam Prabha. Digital India. Educated India.
Hello everyone, welcome to the course on computer aided drug design. We will continue on the topic of ADME, absorption, distribution, metabolism and excretion. We will look at lipid solubility, how drugs which are weakly acidic or weakly basic, how they dissolve in various parts of the stomach, small and large intestine. Okay. For example, like I have been telling that there is a lot of difference in the pH. If you look at pH of the stomach, it is about 1.4 to 2.1. If you go to duodenum, okay, pH changes a little bit, and then jejunum pH is 4.4 to 6.6, ileum it is 6.8 to 8, colon 5 to 8. So, extremely acidic going right up to basic. So, the drugs depending upon whether it is weakly acidic or weakly basic, they will start dissociating depending upon the pH, and so the absorption of the drugs may change dramatically. Some drugs may get absorbed in the stomach, some drugs get absorbed down the line into the small intestine because of the differences in pH. So, we look at that. In human stomach, most acidic drugs and the very weakly basic drugs are absorbed. Okay. So, that is in the stomach. So, highly acidic drugs and weakly basic drugs. Okay. Salicylic acid, aspirin, thiopental, secobarbital, antipyrin, which are undissociated in the acidic gastric contents because they are acidic drugs and pH is also highly acidic. So, they do not get dissociated, so they get absorbed. Okay. So, aspirin, that is why it acts very fast. So, if you want to have very fast acting drug, make it acidic or very little basic, so that it will get absorbed in the stomach. Quinidine, pyrimethamine, antimalarials and basic, they are ionized in the stomach because you have acidic, whereas they are unionized in the intestine, so they get absorbed. So, if the drug gets ionized depending upon the pH, it becomes very polar, so it cannot cross the lipid barrier because lipid barrier is very hydrophobic. That is the strategy. So, if you want a quick acting drug, you try to make it highly acidic or weakly basic. If you want to have a very slow acting drug, then if they are very basic and they will go down the line, maybe they will get absorbed in the small intestine. Okay. So, let us look at the pKa, pKb, which talks about the dissociation constants of weak acids, weak bases and so on. Okay, let us look at it. Suppose you have HA, okay, it dissociates as H plus and A minus. So, the dissociation constant, okay, is H plus multiplied by A minus divided by HA, given like this. Okay. pKa is nothing but log Ka, dissociation constant is pKa is given as minus of logarithm of Ka. There is a relationship between pH and the pKa of an acid. So, pH is equal to pKa plus logarithm of A minus divided by the HA, that is the undissociated form. So, there is a relationship actually. Okay. If you want to find out whether aspirin, for example, okay, it is an acid, pKa is 3.5, the stomach has a pH of 2, blood has a pH of 7.4. Okay. So, what is the A minus divided by HA? That is A minus divided by HA, pH is 2. Okay. So, that comes out to be 10 raised to the power minus 1.5. Okay. So, that means HA is quite large when compared to A minus. That means most of the drug is in the undissociated form. So, it can get absorbed in the stomach. Okay. Whereas, if you look at the blood pH 7.4, A minus by HA will become 10, 3.9. So, HA is quite small actually. So, inside the blood it is dissociated, whereas in the stomach it is undissociated. So, you have lot of undissociated part of aspirin, so it gets reasonably absorbed from the stomach. Okay. Now, what is the formula between connecting pKa, pH and so on for acids and bases, because we used that to calculate here. So, pKa is given by pH plus log of uncharged by charged for acids. Okay. That is why pH pKa uncharged plus log of uncharged by charged for acids. Okay. Okay. pKa is equal to pH of log of, so when this goes that side you will get a minus, so you can put it as reversed. So, pKa is pH plus log of uncharged by charged for acids, whereas pKb is equal to pH plus log of charged by uncharged for bases. So, we used this formula here. Okay. So, pH is 2, so we use this formula. Okay. Now, let us look at a weak basic, for example. For a weak basic, the BOH dissociates as B plus and OH minus, correct. So, for example, if you take this molecule strychnine, okay, this is the structure of this molecule, it is a poison, it is not absorbed until it enters duodenum, it stimulates all parts of the CNS. CNS is your central nervous system, so it is a poison. So, pKb is 5.7, it is a weak base, or pKa is 8.26 of this same, because pKa plus pKb for the same system is equal to 14, if you remember that. So, pKb is equal to pH plus log of charged by uncharged for bases, so we use that formula. So, okay, then in stomach pH is equal to 2, so what do we do? B minus divided by BOH is equal to 3, that is 10 raised to the power 3.7, approximately it could be 10,000. Okay. So, B minus is very large when compared to BOH. When B minus is large, so it is a charged molecule, so it cannot cross the lipid barrier. If you go to intestine, pH is 4, so B minus by BOH is 10 raised to the power 1.7, so we do have enough BOH, so it gets absorbed in the intestine. Okay. So, as you can see here, if you take aspirin, which is weakly acidic, so pKa of 3.45, so it gets absorbed, okay, it gets absorbed, and then whereas strychnine, it has got a pKb of 5.7, it goes down into the central nervous system to get absorbed. Okay. Okay. As we have said, most acidic drugs are absorbed in the stomach, so that is what happening. So, aspirin gets absorbed in the from stomach, whereas as I said, basic drugs have to go down into the intestine to get absorbed, okay, like this strychnine, understand. So, that is a very interesting strategy for designing quick acting drugs, slow acting drugs by changing the pK and pKb. Okay. And this is also very, very important for you to understand, because that will also tell you about the pharmacokinetics of the drug. If it is going to be absorbed in the stomach, you will see the concentration rise very fast in the quickly the concentration of the drug will rise in the plasma, whereas if it is going to get absorbed into the duodenum or small intestine, the maximum concentration in the plasma will take much longer time. Okay. Okay. We have looked at the concept of absorption, okay, that is very, very important. Distribution, let us look at distribution. It is like I said, a big pot. It is not only the blood, even the tissues and other organs will also will be part of this big pot, and the drug can get absorbed depending upon the molecular weight and lipophilicity and so on. So, depending upon the several factors, this contents of the pot may change. Okay. So, when you drop some salt inside the pot, it gets diluted. So, if the quantity of liquid inside the pot is very large, it will get diluted too much, and the concentration will be very low. So the body is a vessel in which a drug is distributed by blood, and it is not homogeneous. So it is not only the blood but many factors. Typical liquid volume for a man of 70 kg, that is in percentages. Okay. 5 major body components: the blood plasma, interstitial fluids, fat tissues, intracellular fluids, transcellular fluids. Sometimes drugs get absorbed in tissues also, because if it is a very highly hydrophobic, lipophilic, it can go. So then your volume increases. So look at this, water, total water in the 42 liters, intracellular volume could be 40%, 28 liters, extracellular volume 20%, 14 liters, plasma volume 4%, blood volume 8%. So depending upon which contributes towards the absorption of the drug, the volume can change. So the volume can change depending upon the nature of the drug, depending upon the health of the patient, depending upon the race, depending upon the gender, and so on. Okay. So volume of distribution, how much dose we give divided by C naught. C naught is the maximum concentration that drug reaches in the plasma. Okay. I showed you when you take oral drug, concentration keeps going up with the function of time, reaches a maximum and then starts coming down because of elimination and so on. That maximum concentration is called C naught. Okay. So as you can see, if the volume is very large, C naught will become very small. If the volume is small, C naught also become large. So they are indirectly related. Plasma, like I said, 3.5 liters, extracellular fluid 14 liters, intracellular fluid 50 liters, even fetus, brain. So they are all special regions where the drug also can get distributed. Okay. So the drug can go and bind to plasma protein, it can go and bind to tissues, that is called tissue sequestration. Okay. And then the drug starts. This is very important, because then the drug has to reach the target. It is not like a small car which will just go directly to the target, but the drug gets distributed, get diluted, and then it reaches the target. Okay. So the distribution affects the concentration at the site of action. Like I said, if the volume is very large, concentration may be much low. Okay. So it might not be effective for it to act. An antibacterial drug should have effective concentration so that it is higher than minimum inhibitory concentration. If you are killing some cancer cells, the concentration should be higher than the cytotoxicity limits of the cells, and so on actually. So for example, warfarin, the volume of distribution is 8 liters. That means there is only plasma protein binding involved. If you take ethanol, ethanol is a very small molecule. Okay, it goes everywhere. Theophylline, 30 liters. That means it represents distribution in total body water. Okay, not only plasma but also the body. Chloroquine, this is a malarial drug. Look at this, huge, because it is highly lipophilic, so it goes into the body fat, everywhere it goes. That is why the volume, that is why the effective dosage, the C naught will get very low. So you need to be given more chloroquine to achieve a considerable large C naught. This is a drug for acute ischemic stroke, 8 liters, because it is highly charged, that means hydrophilic. So it will not go into the fat and lipids and so on actually. So approximately human has a blood volume of 0.08 liters per kg. Okay, so if somebody has about 60 kg person, he or she will have about 5 liters. If the drug diffuses into the body fat, then the volume of distribution goes up to almost 250 to 300 liter per kg. As you can see here, if a very small molecule can diffuse into the fat and so on, so the volume increases dramatically, and the volume increases dramatically, the C naught also will drop dramatically. So as you can see here, almost 3000 times like that, you know. This is taken from this particular reference. Okay, so This is a very interesting graph because it tells you liters per 70 kg or liters per kg, okay, the volumes for different drugs, okay. So warfarin, like I said, I write down. So you can give even small dosage, and C naught will be quite high because volume is low, salicylic acid, okay, because C hydrophilic, okay, theophylline, digitoxin, okay, phenobarbital, like that it goes. Chloroquine, this is your anti-malarial, highly hydrophobic lipophilic, so the volume increases 20,000 or 200 liters per, okay. So highly hydrophilic polar groups, volume will be low, lipophilic volume will be very large, okay. So the drug gets diluted. This figure was taken from this particular reference, okay. So this is the typical curve I have been showing you. So if a person takes a drug orally, this is the concentration, this is the time, so the concentration increases in the plasma, reaches and then it starts coming down because of elimination, okay. And generally this equation we call it Ct is equal to C naught exponent minus k elimination into time, okay. So when we take logarithm to the base 10, then it becomes logarithm of Ct is equal to logarithm of C naught minus k elimination t by 2.303, okay. So the slope, okay, the slope of this line is given by this k elimination. This is a negative slope because it is falling down. So here the axis is logarithm. So when you take this and take an anti-logarithm, you get the okay, get the C naught. Okay, so the distribution is a big pot where the drug goes and it gets diluted. So C naught goes down, and the volume of distribution depends upon the body weight. Volume of distribution depends primarily on the polarity, whether the molecule is charged, small molecules. So it can change by even a factor of 1000. That means C naught can come down by a factor of 1000 also. So it depends on the type of drug. So we need to understand that. Generally it is very difficult to tell what is the volume, but for standard drugs the data is available. So you can go to some databases and find out what is the volume of distribution, like for some of the antibiotics volume of distribution, and also I showed you in some of those drugs database, no, drug DB and all that, and the volume of well documented drugs are clearly stored, so we can get those data very easily. Then comes metabolism. Okay, so now the drug gets distributed, there are liver, there are so many enzymes in the body like oxidoreductases, lipase, esterase, hydrolase, amidase. So they start degrading your molecule. So the molecule can become totally inactive, or you may be forming new side products which may be toxic also. So metabolism is very important, and again metabolism depends upon the race, depends upon the age, depends upon the health of the patient, depends upon whether the patient is taking other drugs. So many factors affect metabolism. So metabolism for a Caucasian could be very different for as against an Asian or as against an African, okay. So metabolism can be dramatically different. Drug molecules are transformed by enzymes because body contains a lot of enzymes, and they have primary metabolism, secondary metabolism. So the metabolism is a very important activity in the body to remove toxic chemicals, but unfortunately drugs also gets degraded during the process, okay. So the drug action may increase or decrease because you may form some products which are totally inactive. So there is genetic variation, a lot of genetic variation that has been seen. They say there are several routes for metabolism, okay. But liver is the primary site, but it can happen anywhere in the bloodstream, that is very important, okay. It is not constant. There could be drug interaction, drug herb interaction, drug food interaction. we take so much food, and interestingly the drug and the food follow the same path. They go to the stomach and they have passive diffusion, goes to the bloodstream, they get metabolized. So they follow the same route, so there could be a lot of interaction between the drug and the food. Okay. And mutations allowing detoxification of natural toxic materials are advantageous, because if the body, and this is a part of the defense mechanism in the body, as soon as a toxin is there, maybe a pesticide, herbicide or any chemical, the body automatically tries to throw it out by transforming it into smaller molecule. Okay. So it is good, but unfortunately drugs are also caught up. So the drugs may be converted less toxic effective material, more toxic effective material, materials with different types of effect or toxicity. So for example, some drugs may get biotransformed and they may have some hepatotoxicity. Okay. So biotransformation is very important, one needs to look at. There are two phases of biotransformation, phase 1, phase 2. So the drugs changes and creates site for phase 2. So phase 1 is a very simple metabolism. You do oxidation, that means you are adding oxygen, okay, using a P450 type of it. You do reduction, that means there is a hydrogen H added or O is removed. Hydrolysis, that means OH is added by esterases. In phase 2, groups are couples groups to existing or phase 1 formed conjugation sites. So glucuronide with glucuronic acid sulfate and others. So phase 1 you may be adding say OH because of this hydrolysis using an ester. Then in the phase 2 you are adding a SO3 group, okay, and this may be very easy to get thrown out from the body, maybe through urine. Okay. So phase 1 is a simple process, oxidation, reduction, hydrolysis. Phase 2 is for the existing groups conjugating with the glucuronic acid sulfates and other things actually. Okay. Okay, what does it do? Cytochrome P450 is one of the important things. Okay. It has 4 families, 1 to 4, 6 subfamilies A to F, up to 20 isoenzymes, 1 to 20. So there are different cytochrome P3A4, P2D6 and so on actually. Okay. For example, if you look at this cytochrome YP2D6 star 17, Caucasian will have 0%, Asian have 51%, okay. Africans have 6%. So there could be reduced affinity for substrates, okay. So that is a problem. You have different amounts of some of these cytochromes. So you may see different biotransformations between Caucasians and Asians. You may see very dramatic differences actually. Okay, so the phase 1 reaction, what happens? Hydroxylation, so you are putting a OH group here, CH2 CH3, so you are putting OH. Oxidation, so we make COH, okay, or we remove a H here, so CHO happens. Even if you remove high H, it is called oxidation, or we can add an O. Dealkylation, N-dealkylation, that means you have a CH3 on the nitrogen which gets removed, okay. One CH3 in the nitrogen is removed. Oxidative deamination, so you are aminated, that means you are removing the NH2 group here into ammonia as well as you are putting a O, that is why it is called oxidative deamination, you understand. So hydroxylation, we are putting okay, OH group, or oxidation, that means you may add an oxygen or remove a hydrogen. Dealkylation, one CH3 from nitrogen is removed, or oxidative deamination, that means you remove the NH2 here and you may put an O here. In phase 2, so you are conjugating it, glucuronide, sulfate, all these groups get conjugated. So it alters activity, it becomes more hydrophilic, less lipid soluble, so it gets excreted because you are adding sulfate and glucuronide. So it becomes more hydrophilic, so it becomes less lipid soluble, so they get excreted. That is phase 2, okay, understand. These are the 2 phases by which biotransformation takes place inside the body. There are other non-microsomal reactions. Hydrolysis in plasma by esterases. As you know, esterases means esterification, okay, like choline esterase, that is in the plasma, not in the liver. Liver we have predominantly P450 type of enzymes, okay. Alcohol and aldehyde dehydrogenases in cytosolic fraction of liver. Ethanol if you have, they get dehydrogenase enzymes dehydrogenated, okay. Monoamine oxidase in mitochondria, especially dopamine, amines and so on. Xanthine oxidase. So these some of these enzymes, okay, which do the biotransformation. Then there are enzymes for particular drugs, tyrosine hydroxylase, dopa decarboxylase and so on. Actually they are specific for different types of drugs. So in addition to changes that are happening in liver, you can also have changes in different parts like esterases, dehydrogenases, monoamine oxidase, xanthine oxidase and so on actually, tyrosine hydroxylase, dopo decarboxylase. So all these can also act on your drug and modify its structure, okay. For example, let us look at this example, impramin tofranil and also known as milipramin. This is a tricyclic antidepressant of the dibenzazepine group. Actually this is a tricyclic, okay. This is used for the treatment of major depression and enuresis, that is involuntary urination. So what all things can happen? You can have biotransformation in various places, okay. This nitrogen, that nitrogen, here. So when you do that, for example you put a OH, this becomes 4-hydroxyimipramine, it is a cardiotoxic, okay. Whereas if you remove one hydrogen here, one CH3 here and put an H, desmethylimipramine becomes antidepressant, okay. So depending upon the type of biotransformation you end up with a product which can have a totally different effect. And look at this, there are many sites for biotransformation. So you can have groups put in here like OH as I showed here, or this nitrogen, and the groups can leave, or here the methyl groups can leave, okay. So the product can be completely different and it can give a totally different activity. So what are the factors that affect biotransformation? Race, because CYP, that is cytochrome P2C9, depends upon the race of people. Warfarin is used for bleeding, okay. European Americans with the variant of CYP2C9 require less of the drug, whereas African Americans do not have that, so they require normal amount of drug. That is an example, okay. Isonicide is used for tuberculosis, it is metabolized primarily by acetylation of liver and acetyl transferase. The rate of acetylation is genetically determined, okay. 50% of African Americans and Caucasians are slow acetylators, that means they have this drug present in the body for a much longer period of time. Rest are rapid acetylators, the majority of Eskimos and Asians are rapid acetylators, that means I need to keep giving the drug quite often because the drug half-life is very small, whereas African Americans or Caucasians I do not have to give this drug quite often. And then you have fast, very fast, 95%, Inuit, they are the group of culturally similar indigenous people inhabiting the Arctic region of Canada, okay. So you have different numbers of this. So the acetylation of this particular drug can vary depending upon the race, okay. So why does it happen? The amount of enzyme that is synthesized is very low, so it does not get acetylized very fast, okay. So that is the big problem actually. So acetylation may lead to higher blood levels of the drug, so increase the toxic reaction. Drug will not be toxic in Asian, that is fast acting, but toxic in African, Americans and Caucasians. So, same drug, race plays a very important role. Next, age, reduced in aged patients and children. Okay. So, biotransformation is much lower in patients and children, so toxicity could be higher. Third is sex, women are slower ethanol metabolizers. Okay. That is why the blood concentration of ethanol in women remain much longer than men. Okay. Plasma concentration of losartan is twice as high in female hypertensive when compared to male. This is a drug given for hypertension. Okay. So, species, phenylbutazone eliminated 3 hours rabbit, 6 hours horse, 8 hours monkey, 18 hours mouse, 36 hours man, because the biotransfer route can change. Clinical or physiological condition, that means health of the patient, if the patient is sick or very healthy, the patient has undergone some operation. Then other drug administration, that is whether some other drug is inducing or inhibiting certain enzymes. Food like charcoal grill can affect because it produces a lot of amine. Grapefruit juice, okay, it can absorb some drugs and start transforming it. First pass, okay. So, initially when the blood flow with the drug flows through the liver, concentration is high, maximum biotransformation takes place. When it comes back again, the biotransformation levels are much lower. Okay. So, we find so many factors affecting the biotransformation, and a drug can become toxic because of the changes in the structural features, and the drug can be toxic if certain bioenzymes which biotransform do not exist, whereas it may exist in some other set of population. Okay. So, the same drug may be toxic in some population, whereas it might not be toxic in some other population. The half life of the drug may change in some population, whereas it may be different in some other population, and so on. So, we will continue more on this ADME in the next class as well. Thank you very much for your time.